we talk with Nick Rosenlicht about what's gone wrong in the mental health care system. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kelly Newsom, a psychiatric NP and a dedicated reader of every issue.
As we were finishing off the final edits of this podcast, we received the news that the CEO of United Healthcare, Brian Thompson, was fatally shot not far from where we were recording in Midtown Manhattan. The words, encased on the bullets, made clear the shooter's intent: deny, defend, depose. A reference to a book from 2020 called Delay, Deny, Defend: Why Insurance Companies Don't Pay Claims and What You Can Do About It. Well, there's a lot you can do about it, and we're going to get into that in this podcast, and murder is not counted among them. But this podcast is not a reaction or a response to the events of the shooting. It's a reaction to a crisis that has been long-standing.
Nicholas Rosenlicht, MD, has worked as a psychiatrist, teacher, and researcher for over 4 decades. It's a career that has seen major advances: clozapine, Prozac, TMS, and dialectical behavioral therapy. But he's also witnessed a degradation in how we care for people with mental illness. And that is the subject of his latest book, My Brother's Keeper. Today, he talks with us about insurance denials, private equity takeovers, and how to reduce burnout in the age of healthcare productivity. Stay tuned to the end for an important clozapine update.
You argue that healthcare has become a business where patients are called clients and doctors are providers. So what's wrong with all that?
Mental health has been sort of extruded from healthcare. It's not viewed as an illness. And I think public sentiment is changing, but in the past, the majority of Americans have not believed mental illness is real. And part of mental health field has played into that. For example, calling people clients. Client implies it's a business, it's a decision that somebody else is going to fix the problem to you, not that it's an internal illness that you need to have assistance, but the burden of the healing happens within. And it turns into a business deal, which allows it to be extruded. Like, why would health insurance pay for a client relationship?
I can see the argument, though, that it's more respectful or humanizing to call people clients instead of patients.
I think we do that because we all are steeped in the whole stigma of mental illness, that calling somebody a psychiatric patient is really damning. Brings up, evokes visions of insane asylums and people being insane. And who wants to be called a psychiatric patient? But in using a euphemism, it may make it more palatable for us to talk to somebody in the end of care. But in doing so, we're actually perpetuates and strengthens the stigma. But, we won't talk about it either, too, because it's really kind of disturbing. So we perpetuate it by trying to sanitize mental illness and think we can handle it with wellness or groups or the right diet. I mean, everything is important, but to not really view these as illnesses and people as patients, I think, is a mistake. And that's what our model has been. It's viewing it as a business model, and making it a business model makes it more ethically palatable to exclude people from care or give them bad care. Because after all, it's a business decision to not treat somebody because they can't meet the terms of the contract or deal. They don't have insurance, they don't have funds, or they're not choosing to, or they don't have the insight to realize they need care and they won't pay, is a lot easier than saying, I'm not going to treat you, and I don't care if you end up on the streets or in prison or dead. It makes it a lot easier for us to deny care the way our society does.
How does our society carve out the sickest among us from care?
One, you generally have to be employed to get insurance. The seriously mentally ill, employment is hard. We used to provide sheltered workshops and jobs, and in the asylums, people had jobs. And that's an important part of self-esteem and being part of society, is to work. So it's based on employment Or if you're not over 65, Medicaid, which is incredibly cumbersome and administrative. And who's going to be able to handle the administrative task of receiving and managing yourself on Medicaid when you're homeless or you don't have a cell phone? And people are often estranged from their family. We don't provide the resources necessary to keep people in care. It's very hard to negotiate our system. Visits to psychiatrists are self-pay, out of pocket, 15 times more often than those to primary care. Again, we're pitting companies who are intending to make money against people who need care, and they are in opposition. You provide care, it costs money. Think about it. Health insurance is really not kind of insurance. Insurance, it's a pooling of resources. People pay in to avoid a catastrophe, like your spouse dies or your house burns down, and the community all shares in a small cost, so you will be okay. But health needs are not rare. They're needed, especially preventive care. We all have to get care. So it's not really insurance. So we have this industry which is supposed to take care of us, but their goal is to make money. And that's why there have been so many scams to get around parity, insurance coverage for mental health. I think there's also something around the privacy of mental health care because of the shame and embarrassment and all that people, their families, and we don't advocate enough. I think we could get together as groups to blacklist or shame even some companies that are unfairly discriminating against the mentally ill. I know in California, for example, Kaiser's been fined for their lack of providing mental health care, and I think others. But often these companies just find paying the fines is cheaper than actually providing the care.
Some recent laws have tried to address those problems, like parity law and laws against excluding pre-existing conditions. Well, how have those moves failed?
The Affordable Care Act did have the number of uninsured, but it also entrenched the current players whose interest is to exclude mental illness. I mean, it's like whack-a-mole. Like I just read about this company, Evicor, sort of like the pharmacy benefit managers. It's a company that tells insurers, you pay me $10 and I will save you $20 by denying claims. And, we don't get reimbursed for fighting claims or filling out PARs. With each roadblock that's put up, enough people just give up and won't do it. So it's really a game of whack-a-mole. And I think that's why 50% of psychiatrists don't take insurance.
And all of those whack-a-moles create a bureaucratic wall that prevents parity?
I mean, I think just in denials. Psychiatrists tend to have less of a system around them. We tend to be more solo practitioners than, internal medicine or surgery clinics who will have dedicated people who fight claims denials. And as psychiatrists are now working more and more for these groups who often are owned by venture capital companies, they are not interested in spending time fighting these things. They will just go after resource-rich people who can pay out of pocket. And I think with all these roadblocks, more and more we just go for the high payer. And people who can't pay or are difficult, the work to get them care is just not profitable or practical over time. And the time it takes to fill out people's individual forms, and then you have to hire a biller. I think psychiatrists find it's just easier, take less payment and just not have to hire other people. It's so costly to have an office where you might have an office manager or a biller or people to manage this stuff.
This sounds like an ethical dilemma. On the one hand, we can take insurance even though they may compromise our ability to deliver good care, or we can go private pay only and be free of those restrictions. But when we do that, we're also carving out a lot of people and moving toward treating just the worried well who can afford those kind of rates.
Well, it is a very real dilemma. I think some of us, what we do is I do that. I see wealthy people, but I also do some pro bono or low bono work. And I have things like maybe I will charge people twice what they make as an hourly wage, or do some pro bono work just to feel like I'm doing the right part for society. And some people are paying more, but if you're not paying an office manager and all this stuff, you can do that and make a decent living. I think as cost of living has gone up and wages have gone up, we've gotten on the escalator expecting a lot of money. Yes, psychiatrists didn't used to make a lot of money that way unless you were treating diseases of the rich only.
What are some of the models of private pay that psychiatrists are using when they don't take insurance?
There's concierge. People buy in for an annual fee to get care. That's still, there's a problem in that a concierge fee might be prohibitive to one person, not for the other. And then the incentive is also to minimize care because, once they've paid their fee, why would you want to spend a whole bunch of time on them?
Is there any hope of changing all this, or at least negotiating with insurers?
I think we have a whole lot more power than we think when we stand up to insurance companies. They are not negotiating. It's not a business deal they're giving us. They're giving us a non-negotiable contract if you sign as a provider. How is that fair? And why should we do that? That we are just taking what they say. It means essentially you are a gig employee of that company where you have no rights, you have no say, and you take what they say you can have. How is that a fair deal? There's a paradox in that we are in demand. People need us. Why is it we have no power? We are the ones the insurers need. And it's really sad. I get calls every day from people wanting care, and I'm really as full as I can be, and I want to be. I think it does mean banding together a bit more. Your physicians aren't supposed to strike. Our work is so private that actually getting together and talking with colleagues about, well, no, maybe this insurer is doing better, we'll take that one. And they're forcing insurers to compete with each other to do a better job, gives us more power. There's that courtesy stigma about being a psychiatrist, and that we're a Hannibal Lecter, or we're what about Bob, we're inept, or we're corrupt. I think having a better public face and talking about what we do and how people can access us and the way we do our work is important. I think our organizations have been too allied with pharmaceutical companies and big money rather than serving the needs of what psychiatrists and their patients need.
What should we look for in an insurer to make sure that we contract with the ones that support good care?
One thing is, I think, be careful about the groups you join. Make sure it's one run by psychiatrists. Why do you want a company that is making money off of you, hiring you, and these places with non-compete clauses and all that? But again, it would be talking to your peers. Like, who do you contract with and who not? Who has worked out well? That puts the pressure on the companies to do a good job. Otherwise, people won't work with them.
Okay, you just brought up non-compete clauses, and I want to get into that more because those are really ethically problematic. Not because they keep doctors from earning a living in certain cities. We can always find jobs, but because non-competes break up continuity of care for patients by preventing patients from following their doctors when they switch jobs. So what's happening with non-competes? Isn't the government trying to get rid of them or something?
Well, yeah, but apparently nonprofits won't be bound to them, and there's ways around it. And there's so many nonprofits in health now that just means they don't have stockholders. They're still making profit.
Yeah.
So that's going to be tied up for a while.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. 1. True or false? According to Dr. Rosenlicht, the majority of outpatient psychiatrists accept insurance.
Private equity started buying up mental health practices a few years ago. What is happening with mental health centers that are not physician-owned?
Venture capital and private equity, they're on these 7-year models to sort of pump up and dump, make some money and then dump it. And that doesn't work in healthcare. I think private equity venture capital, the largest investors in mental health over the last few years, because the profits can be so great because of the model of just squeezing people because they're so desperate. And it's really unfortunate that they're doing that.
Well, we've talked about a lot of problems today. What are your solutions?
I think we need to move towards a single payer. I mean, I know people are scared by that, but every other developed country does that. And we do that, and we also view like the brain is not different than other organs. It should be covered equally, that there shouldn't be different restrictions on care. I mean, we shouldn't even talk about parity, just the idea of there being a different care for diseases of the mind than of the liver just shouldn't occur.
Some clinicians are being pushed to see more and more patients per hour.
I can see, 4 people in 2 hours and, make a lot of money charging them if they're just half-hour visits for meds. But, I don't feel I know them as well. I didn't cover all the bases. Maybe I'm old school. I used to work in training. You work like 80 hours, but you didn't burn out. You were tired because it felt fulfilling. Because you felt like you were doing the right thing. You made a connection to people. You felt like you were being complete. And you weren't spending time on things like paperwork. When I sit with somebody and I don't feel like I'm hurrying them, I'm being fed too, because it's the relationship. It's the reciprocal care that most of us went into medicine for. And burnout it's not just workload. It's about lack of control and the lack of feeling that you're doing good care. What really feeds us is the feeling that we're doing a good job. A half an hour already feels rushed for me. And, that's my training, I guess, in being old school and getting older. But I just would feel like a vending machine. And yes, I'm making a living, but I worked hard to get into medical school and go to medical school and then residency training and, all this stuff. And I'm making an okay living. And at this point in my life, I'm not starving. It's more important to feel like I'm doing something that I enjoy and I'm helping people. Generally, happiness is more about not what we're doing for ourselves, but what we're doing for other people. And I think that's why most of us went into medicine. That's what feeds us. And to get back to that rather than, the dollar.
You said that you were inspired to write this book by negative changes in healthcare that you saw throughout your career. On the other hand, did you see any positive changes in your career?
Well, I think the public's view has changed. There was a time, where a vice presidential candidate was kicked off the ticket, Eagleton, because it turns out he'd had successful ECT and was all better. But now you've got people like Fetterman coming out with describing his depression. The number, I forget what it is like 30% of Americans know somebody who's died of a drug overdose. So I think that has really shifted. Treating mental health is cost effective. People use less other health care, and it saves money if we do this. And I think there is a public awareness now that, mental health does need to be addressed. So we have an opportunity now, and it's going to happen through legislators. The healthcare industry is the largest lobbyist in this country, but I think through people saying, no. This is part of a good world, is us taking care of everybody, including their mental health. It just makes everybody happier. So I think there is an opportunity now, and that's why I was reaching for it. It's in the public eye now.
Thank you, Dr. Rosenlicht.
Last month, an FDA advisory committee voted 14-1 to end the clozapine REMS program. We expect a final decision from the FDA in the coming months, but it's likely they will end or significantly loosen these restrictions, which require labs every 1 to 4 weeks before pharmacists can dispense the antipsychotic.
Clozapine was developed in the 1960s and first released in Europe in the early 1970s, but it was quickly taken off the market because of alarming cases of agranulocytosis, a fatal drop in white blood cells that occurs in about 1 in 100 patients who take the drug. At the time, clozapine's main advantage when it was released was that it did not cause tardive dyskinesia, something that was getting to be a bit of an epidemic in the 1970s as doctors were turning to higher and higher doses of antipsychotics to try to help people who weren't responding to them. It was only later that we learned of clozapine's benefits in treatment-resistant schizophrenia, a discovery that led to its rebirth and U.S. release in 1989. John Kane, who led that movement, as well as the landmark trial that showed clozapine could work for patients who failed multiple antipsychotics, spoke at the recent FDA meeting.
When clozapine was first released, the FDA required weekly blood draws indefinitely. In 2005, the regulations were relaxed to allow monitoring every 2 weeks after 6 months of treatment and every 4 weeks after a year. The change followed the evidence. Most serious cases of agranulocytosis occur within the first 4 to 5 months of starting treatment, and by 2 years, that risk is almost negligible.
We've also learned a few things about clozapine that put its risk in perspective. First, patients live about 10 years longer on clozapine than they do on other antipsychotics. Why? Well, I doubt that clozapine has anti-aging effects, but I do believe that a healthy brain is critical to a healthy body. Second, the regulations, the REMS, appear to be causing more harm than good, with over 60% of psychiatrists saying that the REMS program prevents them from using clozapine. The U.S. lags behind all other countries in clozapine use, with only 5% of U.S. patients with schizophrenia taking it, 5%, while the rate of treatment resistance in schizophrenia is 25%. In some countries, 25% of patients with schizophrenia do take clozapine.
Agranulocytosis is serious, and we expect that regular monitoring will be part of the standard of care, if not part of a REMS program. But it is not the only thing to worry about on clozapine. The rate of death from severe constipation, bowel obstruction, and ileus is actually greater than the risk from agranulocytosis. So ask your patients how often they are having a bowel movement on clozapine and treat aggressively, starting with Docusate, Senicide, combination first line. Seizures, metabolic syndrome, myocarditis, and arrhythmias are also important risks. And this year, a study identified higher rates of pneumonia as a possible risk from clozapine.
With so many risks, it's amazing that patients live longer on this drug. But that is a not uncommon paradox in psychiatry. Both lithium and clozapine have more medical warnings than other drugs in their class. But lithium and clozapine are also the only drugs in their class that robustly lower the risk of death in bipolar and in schizophrenia. If you've been avoiding those options because they seem too risky, think again.
Nick Rosenlicht is a clinical professor of psychiatry at the University of California, San Francisco School of Medicine, and operates a private practice in Berkeley, California. His 2024 book, My Brother's Keeper, The Untold Stories Behind the Business of Mental Health and How to Stop the Abandonment of the Mentally Ill, is available from Pegasus and Simon & Schuster Books. Read the full articles and earn CME credits at thecarlatreport.com, where we have a special offer for our podcast listeners. You can get $30 off your first year subscription with the promo code podcast. That helps us stay free of influence from the pharmaceutical industry and bring you unbiased information you can trust.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.